Welcome to everybody who's here. I'm Dr. Abigail Hirsch. I'm a co-founder at Lynn Health, also a clinical psychologist. And joining me today is Charlie Merrill. Charlie, you want to give a quick introduction to yourself too?
Sure, of course. Hello, everyone. I'm Charlie Merrill. I'm a physical therapist here in Boulder, Colorado, and I'm also a clinical consultant with Lynn Health, working in lots of different parts of the platform. And I'm right now in charge of scaling our coaching team, which we'll talk about a bit, which is sort of at the center of Lynn.
We're here today to really talk through a whole bunch of new understandings about chronic pain and really specifically hopefully get you some thoughts on why it may be that your pain experience or the pain experience of people you care for is continuing despite all of your best efforts. And as we know, probably many things that you've tried over the months or years. But before we get going, just a few housekeeping things. I want to make sure everybody knows that Charlie and I will be having a conversation here for about half an hour. And then we'll use the back half of our time together for question and answers. But we really encourage you throughout the course of our conversation, if you have a question that pops into your head, please do use the chat and send it in right when it pops in your head. We have a support team here, Alyssa and Sarah, thank you very much, who'll be fielding those and getting us a question queue to answer at the end of the conversation. Maybe we can just kind of pull up a little bit of our agenda side, just so folks have a little bit more orientation to the kinds of topics we want to be looking at over the next hour here. The first thing is we want to just discuss a little bit about how big the problem of pain is. And next, we're going to talk some about what our current approaches have been to pain and what are some of the challenges with them. And then really look into some new solutions that are coming out of incredible new research from the neuroscience community. Let's just chat a little bit. Tell me how much pain is there out there in the world?
It's an epidemic problem at this point. The estimates are anywhere from 1 in 4 to 1 in 5. So, 25% of people are in some form of chronic pain. And that I think that number is shocking because it's bigger than heart disease, diabetes, and cancer combined, not only as far as how many people are dealing with chronic pain, but also the cost to society is also outstrips all of those other diagnoses. So when you really look at the numbers, it's kind of shocking that despite the best efforts of our current medical system, these numbers continue to go up year after year.
Yeah, and so that's a really interesting piece about the numbers going up year after year. I think it's actually really surprising. We live in a world that's relatively safe and relatively one would think that pain shouldn't be going up and up and up. It's certainly not due to disease or, rough physical conditions. Just tell me a little bit more. What do you think? Why are we in this epidemic?
We have two decades of research, basically reinforcing what we're going to be talking about today, that not all pain is the same and that pain is really different from the way we thought it was. So this old Descartes model of pain is somehow directly correlated with tissue damage really hasn't been true for a long time. And yet that evidence hasn't really made it into clinical practice yet.
I love what you're saying about the Descartes model. And I think we do have a slide for that in the deck that you have. Maybe we can pull that up. But, Descartes was a philosopher, but also kind of an early scientific thinker. And he had a really interesting idea for his time about what pain was. He has a kind of a classic picture of a person reaching in to touch a fire. We can kind of see in his image from where the hand reaches that hot sensation, kind of a cord is how he thought of it, that goes up into your brain and makes some kind of signal, and then another cord that sends something back down to your hand. So of course, these days we know those cords are called nerves. But Descartes' image was that pain always started from a physical stimulus, right? From something that was bad for the body, like a fire. Then the brain got the message and then it sent the pain back down. And until really recently, this is how we thought of pain, that pain was something that happened because something was broken in your body or was getting broken in your body, some kind of a tissue damage or structural damage.
Yeah, and we call that secondary pain now. when we refer to it, these two different types of pain. Secondary pain is pain that's secondary to a body problem or a medical condition or a tissue damage problem. And primary pain, this new category of primary pain, is really about the pain itself being the problem. And because, we'll get to this, but because we look at all pain through the lens of the brain and the nervous system, primary pain is really the brain and the nervous system generating the sensations that people are experiencing, sometimes in the complete absence of any body problem at all.
It's so interesting, Charlie, and maybe we'll just talk about this for a minute. What's different in our current model of pain, that we've really moved away in the current neuroscience from this kind of Descartes understanding that it's a external or a damage signal that goes up to your brain, and then that gets noticed, and then we send the pain back down from the brain. Although Descartes did understand a really fundamental piece of pain, which is that all pain involves processing in your brain. That's super central to understanding any kinds of pain. But today we understand that there's some really different processes that start to happen, especially around primary pain, which is the vast majority of chronic pain. And I think we have another slide here also, but it turns out that our brains have an incredibly important role when we're looking at pain, that not only do they sometimes receive stimulus from our bodies, but they also actually are actively out there helping us to protect us preemptively almost from pain. And so they will respond with a pain signal even when there's absolutely no damage in the body or something that could be at risk of damaging the body. They respond to other things that have kind of gotten associated with pain. Charlie, I know you're a wealth of stories on this. You want to give us some examples?
This idea that we used to think that pain was an input. So that pain started in the tissues and then made its way up to the brain would register it. Now we know that's not the case at all, and the science has flipped it for us. So now we know that there's information coming into the brain, and there's information coming from all kinds of different parts of our body all the time, but there's also information coming from the environment. And the brain has to decide based on that information what it's going to do, how it's going to react. The brain's job is to predict, to sort of anticipate whether we're safe or whether we're in danger. And so if the conditions are right and there's enough input coming to the brain, either from the body or from the environment, it can choose to make a decision to predict danger. And pain happens to be a really effective way to get our attention, essentially. And yeah, I have a ton of stories about how this works. I guess maybe a simple one just that speaks to the idea of back pain is a client who was just sort of pushing light snow off of his sidewalk, and then seemingly out of nowhere, collapsed to the ground in 10 out of 10 pain. His wife had to help him up. And then he shows up in my office about 6 weeks later, and he's still in a lot of pain, thinking that something had happened to his back. And as we start talking about, what he tried, because he tried physical therapy, he tried all these things, he tried medicine, and none of those things were working. As we started to explore what was going on for him in that moment when he was just pushing this light snow off, and he collapsed to the ground, we started to make these connections between what was going on for him at that time of year. It happened to be early December. And there was an important time marker for him where he was having these unconscious feelings of grief because both of his parents had passed away the year before. And he wasn't recognizing that consciously, but his brain said, wow, something doesn't feel safe. And that was his brain's decision. That was the way it decided to get his attention. And what's amazing about this is after 6 weeks of suffering and trying to figure this out, and all the fear that comes with your body hurting, because of course all pain is real. He had very real pain, even though his body was okay. Within a few days, his back felt better, just from making that connection and reconceptualizing what the pain meant.
Charlie, there's something you just said that I just love, and it's so important. You kind of said, oh, of course, all pain is real, but it's so often when people are learning these ideas that it can feel like somebody's saying, like, this is made up pain, this is not real pain. And it's so important to understand that all pain really is real, and whether the source is coming from a structural signal, which it is in some cases of acute pain, but as your example shows, in many cases of a new pain, it's actually has nothing to do with structural damage. But certainly as pain kind of persists in the brain, the pain stays really, really real, even if the source, the trigger for the signal is increasingly our prediction that something could be dangerous, as opposed to the input coming up into the brain. I like all the time to talk about that pain is a process reaction, same way vision is. Actually, you've got your glasses on today, and they're pretty cool glasses. But I always like to kind of talk with people about, what happens when you put your glasses on and off, right? When you put a pair of glasses on, your brain does a really quick refigure out what to do with the sensory input that's landing on your retinas. And the reason we can see with our glasses on, with our glasses off, maybe not quite as well, but we can make that adjustment, or we can put sunglasses on, and after just a couple minutes, the world doesn't look dark anymore, it just looks normal, is because all of our sensors, our eyes, our ears, our taste, our smell, and all these sensors that live in our body, they're just data gathering resources, but the way we experience vision and smell and taste and sensations in our body, it really has to do with what does the computer do with those inputs. Really what we want to think about is that doesn't matter how the computer is, what's the input into the computer, whether it's more sensory coming up or whether it's more learned, always, like in Descartes' model, actually, always our experience of pain has to do because the brain sends something back down, but that doesn't make the pain any less real. It's 100% real pain, and it can be excruciatingly painful, even if there's not actual structural damage in the body. So yeah, you want to talk some about this slide? It's really, really interesting when we look at imaging studies, what's different in the case of acute, meaning kind of pain that's lasted less than 3 to 6 months, versus pain that's more chronic. It's lasted more than 3 to 6 months.
So what we see on functional MRI, these are basically images of the brain using MRI technology, showing what parts of the brain are lighting up, where there's activity, where there's energy, depending on the person's situation. And on the left here with acute pain, we see that the brain lights up in more of these sensor and motor processing regions that are really sort of make sense based on a tissue damage, some type of traumatic injury or car accident.
So that is more like what it would look like if I showed somebody a new picture or a new smell, right? It's those kinds of regions that would light up.
Right. Yeah. Yeah. And so, early on in the injury process or after someone's had surgery, you're going to see the brain light up like it does on the left. As healing happens, which it always does, it's very dependable and reliable. And I like to say we can count on it. Let's say 2, 3, 4 months down the road, if the person is still, the brain is still predicting danger, you're going to see it light up like it is on the right. And now the brain areas you can see are totally different. Now we're dealing with areas that deal with learning and memory, emotion and meaning making. And so, it's not always this clean and simple, but you kind of get the idea that because now we're dealing with this overlap with these other brain areas, suddenly our thoughts and our feelings are affecting our pain experience. It becomes very contextual. You see the word learning up there. Pain, essentially, like any skill that the brain learns, is something that can be learned. And once we've learned it, it can just continue to run on repeat like any habit. And so, like we say to a lot of our members, while all pain is real, this guy that collapsed on the ground, even though he didn't have a physical injury at the time, his pain was very real and his muscle tension was very real. These are real outputs that the brain decides to use to get our attention, but these are the result of the brain being a danger alarm, not necessarily the primary cause of pain.
One place I love thinking about this kind of learning role is in the case of migraines. We didn't talk so much yet about all the kinds of pain experiences our brains are super good at using as tools to try and keep us safe, but migraines and tension headaches is definitely one of them. Fibromyalgia, kind of pain all over, all kinds of experience of pain in our bones and our muscles and our joints often have this learned component. But I like the case of migraines because people are so used to thinking about migraines as being triggered, right? Like, oh, I get a migraine when I'm exposed to a bright light. But part of what's happening there is that our brains are really good at learning. And so somehow, somewhere, they learned like, ooh, bright light, got to be protective. Maybe at some point, again, who knows? It's so hard when it's been around to track down what was the original thing that got learned to it. But somehow, in the case of these triggers for migraines, one's brain has paired a perfectly innocuous stimulus. There's nothing dangerous about light, bright lights, dim lights, etc. But our brain has gotten paired that, ooh, I gotta protect in that moment. And so that's why those triggers are so prominent in the case of migraines.
Yeah, this is really just like classical conditioning, right? The brain happens to be really good at learning, and just like Pavlov in his experiments could condition a dog to salivate when it heard a bell, our brains can pair anything and create a neural pathway from anything. So it could be weather or wine or chocolate or a certain chair or a certain situation.
People or stress at work or
Sure.
driving or
And what's so interesting about migraines and headaches in general is that we know from the research that 90+% of headaches are primary. They have a primary cause, meaning they're exclusively driven by the brain in the absence of any medical problem, which is fascinating. And clinically, when I talk to people who have had years of migraines, sometimes it's been 40, 50 years, and I ask them when they had their first migraine, universally, they almost always remember when it was. And they almost always remember what was going on for them in their life when it happened. There's usually a significant life stressor that they can tie back to, no matter how long it's been. So I find that really interesting.
Somewhere there's some of that original associative piece that's stuck. It's just we're not asking about that very often. And unless, of course, you're working with us, and then we're asking about that a lot, but we'll talk about that in just a minute. So given this new understanding of pain, that pain is not just something that happens because there's structural damage. In fact, in the vast majority of places where there's pain that's persisting for, again, past normal healing times. And by the way, Charlie, I really appreciate the way you were saying, like, bodies heal. Bodies are really good at that. We're these incredible healing machines that stitch joints back together and regenerate discs in our backs. And what's really happening is we've turned on this cycle, right? Where we have a pain experience, and then we get scared because a migraine hurts, or our ankle hurts, or our shoulder hurts, and we start to worry. Maybe because we've heard that, a shoulder hurt is the beginning of something that's going to need surgery, or a back pain might mean that you're going to be stuck in bed for months, and you have all this scary imaging findings. And actually, maybe we'll talk about imaging findings in just a second here. But that fear actually triggers the brain to produce more pain, because here's that fear that you're thinking about, and it's like, ooh, danger, I got to protect you more. And so really, in a subconscious kind of ironic way, we get stuck deeper and deeper and deeper down this fear pain cycle. Often people talk about centralizing and sensitizing of the pain. We get more and more pain experiences and more parts of our bodies, and we get where it takes less and less and less trigger to make that pain experience begin. Often people aren't even aware that the fear is a part of it, but it's always there as one starts to tease it out a little bit more.
We feel like Lynn is sort of a coalescing of all of the best research and all of the best clinical strategies to be able to support people in recovering from chronic pain. I'll just say briefly, like that term central sensitization has really fallen out of favor because it starts to pathologize or medicalize that something's wrong with the nervous system and the brain. And we like to actually normalize this, because this happens to all of us. It happens to me, my kids, my wife. Everybody experiences primary pain at some point in their life, and it doesn't mean there's anything wrong with your brain or nervous system. It's a totally normal thing that happens all the time. But this new model is really trying to interrupt it so it doesn't continue. It doesn't get wrapped up into this cycle of catastrophizing and fear. One of the most important parts of this new model is supporting people in getting an accurate sense for what's going on with them. So through Lynn, we connect people really early on with a diagnostic consultation with a physician or physician equivalent that can help them make basically a rule out of the body, to rule out any medical structural conditions. And of course, we can't do that for everybody because some people have those secondary problems. And in those cases, we sort of think of this as we can acknowledge there's something going on medically, but we also have the opportunity to work with the brain and nervous system to sort of dampen, down regulate the person's pain experience by reducing fear. I mean, really simply, pain and other symptoms are a direct correlate of fear. So even if you've had surgery, even if you've had an injury, the level of fear is going to determine how much pain you have. So this first step is so important, really having people feel confident about what's going on or what's not going on with their body. And then we collaborate with the physician, our clinical team, to really create a personalized care plan. And that's why I think Lynn is so unique. It's not an app that's passive. It's really a platform that is interactive, it's personalized, it's experiential, and it's directly connected to people that really know this model, and they really know how to do this work, and they care, I think, most importantly. So once we've created a plan, sometimes there can be a behavioral health specialist involved. Not everybody needs that, but everybody's connected with a coach. And as I said before, the coach is really the hub of the platform. And the coach is sort of your guide. They're not there to fix anything. They're there to work with you and be a support with you to sort of discover what you might need. Of course, behind the coach, there's this whole consultation team of really smart people that are both research oriented and also clinically oriented to really help to make sure the plan is going where it needs to go, adjusting course as needed as the person goes through the process, and then really connecting people with other tools they might need. Some of those are within Lynn, and some of those are outside of Lynn with regard to sleep or weight or movement or mental health concerns.
One of the pieces I really like when I kind of look at this is the feeling of hope that comes with it, right? The knowledge that there actually is a system to help you get the learning you need and the practice and be with you day in and day out to reverse that cycle. Because for many people, it's even hard at the beginning just to wrap their heads around some of this science we're talking about. It's really different. You know, most of us hear that old Descartes view. And so to have your coach available, and our members have unlimited access to their coaches. So they're messaging on average 2, 3, 4 times a week, hopping on regular check-in calls. And to have somebody to, help keep bringing you information as you need more, what we call pain education, learning more about pain and how it works, but then really starting to look inside of you like, oh gosh, do I have some of this fear cycle going on? And where can I notice that? And where can I notice that there's some ways that my pain is behaving in the specific kinds of ways that pain that has a large learned component to it, a large brain component to it, as opposed to a structural one. We want to not just know it out there in the abstract, but we really want to look for it in me and see if this is really what's happening with me and come to believe that. And then learning the tools and the new habits, again, just like, I don't want to say it's like training a dog, because clearly we are not dogs and we're people and we're complicated, wonderful folks. Once we really understand what pain is, and we're seeing that that's how our pain is behaving, our coaches work really in 4 areas to help learn new cognitive, which means kind of the way we think, behavioral actions, like how much we get out and move, for example, somatic, which means how we experience sensations in our body, and emotional, like what do we do when we're mad, for example. But to learn tools in each of these categories and learn them and practice them and re-practice them and relearn them, and have someone who's with you to figure out what's working and what's not working, and is this the right tool for you, or do we need to adjust to a slightly different tool, and how do we change the tools when pain is high or when pain is low. But our coaches just day in and day out bring in a really structured approach to helping people learn a new set of habits so that their brain no longer is stuck in that fear cycle, but is really able to kind of get on the exit ramp and turn down that signaling of pain. Maybe the most fun about this, just I know for me as a coach, but when I'm coaching and also for all of our team, is that a huge part of what we're doing is also helping people get their lives back. And so shifting pain out and bringing in activities they love doing, finding new activities, spending time with loved ones in a way that they haven't been able to maybe for a very long time. And that's incredibly, incredibly fun to get to be a part of that transition in our members' lives.
People changing their lives is one of my favorite parts of the process. And the other thing I think that is really amazing is being able to make meaning from symptoms, and that can be really reassuring to people. Like, it's not just senseless, right? There's a real reason, and in making meaning, oftentimes it leads to real growth in people's lives. And I think that's one of the most beautiful parts of the process for me as a patient.
Really agree with that. Somebody wanted to know if we're saying that the brain actually gets better at learning how to make pain over time.
It's a great question. Yeah, I think that's fair to say that the neural pathways that are set up that connect certain things to pain, I say sometimes they get burned in, or they go from being like a little single track trail to like a big superhighway. And the work is trying to take a new, like to reroute and take a new path, create a new neural pathway to let that old one just sort of be pruned away, grow over, however you want to think of it. So yes, the learning can get stronger over time, especially if we're reinforcing it with ongoing strong feelings, ongoing fear thoughts, and the more we do that, the more we practice that, like any skill, the better we get at it. So if you think of pain like learning to ride a bike or learning to juggle or something, or playing an instrument, the more you do it, the better you get.
How do we unlearn pain? So the first really important part to know is that this again, it's not a habit anyone did on purpose. It's not, there's no judgment to this. The pain is still real, and pain really can be unlearned. But I think the most important thing about unlearning pain is you do it by making little step, lots and lots of little steps, and lots of having someone at your side who's helping you celebrate the victories, so that we're really reinforcing instead of the screaming of the pain, because pain is meant to really reinforce the pain highway. But what we're able to do with our members at Lynn is provide an alternative voice that's reinforcing the forward motion and the new skills and the new habits that we're building up, so that it's kind of moving off the super highway and letting the pain signaling drift back towards just being this little pathway that occasionally, I get a little tweak or that or the other thing, but I'm able to just say like, oh, okay, what do I need to learn from that? What's my body saying? Oh, okay, and then move on.
It's really just bringing the brain habit down from being really vigilant to things back down to a more normal state. Like, for instance, my brain doesn't tell me that I need to get up from sitting until like the end of a 2-hour movie. For some people, the brain gets in the habit of doing that after 30 seconds of sitting. And so we want to try to repattern the nervous system in that neural pathway, so the brain reacts in a more, I'll say, normal or more helpful way. I mean, at some point, your brain's going to tell you to get up. It's going to make your back sore. It's going to make your butt sore. That's normal. We want that to happen, just not too early.
Yeah, for me, I would say years, but decades is more accurate, was scared to run because I would get discomfort in my knees and my ankles whenever I try to run, and this weird itchy sensation too. But the more I've learned about all this pain science, now I'm very proud that I can run a consistent few K, which for me is a huge deal. Again, we have athletes who are back to running 50 miles a week, but mine is a little more modest. And I still get little twinges sometimes, right? My ankles will speak a little, or my knees will speak a little, or I'll get a little itchy, but it's so different because I've learned the habit to say like, oh, great, that's what a knee feels like when it's getting stronger. That's what an ankle feels like when it's getting warmed up. And when I approach with these new habits that I've just learned slow and steady over time, discomfort goes away very, very quickly, and I'm able to just really enjoy getting stronger and doing this activity I always wanted to do, but was never did before. Will the recovery program from Lynn support issues like anxiety and depression symptoms? Yes, of course we do, because that's part of the learning we need to do to get the pain to turn around. And so some of that we do by kind of more directly in our work on relearning patterns around pain, that it's, incredibly helpful for depression to, for example, be able to be more active in your life. And so when we can get the pain to settle down a little, we can use some behavioral activation techniques. It's a really classic and important way for attacking depression. But that in turn is going to leave us more energized, leave us feeling better, leave us more proud of ourselves, which is going to help the depression go down. But sometimes we need to really, really be there at your side, helping really directly with depression or anxiety. And we have a variety of tools that we use to help folks learn some skills around sleep, around depression, around anxiety, around how they're eating. Not so much that the food is probably causing the pain, but for some people, there's some connections there and some things that they want to do just because they'll be proud of doing them. And we want to have our focus on doing things that we're proud of, instead of doing things that we're worried or fearful of.
Psychology and our social realities are all on the table here when we're talking about why the brain is getting into this habit. There's also a question that I want to just speak to here, because this is my wheelhouse around manual therapy, and we can consider body work, like massage.
Will you just read the question, Charlie?
Yeah, sure. In relation to manual therapy, is a traditional approach of pushing on painful tissue, reinforcing the learned pain? It really depends, which is the answer to lots of questions. If the pushing on the tissue is really uncomfortable and is increasing the fear in the person that's being pushed on, and the clinician hasn't explained their intention or hasn't explained how pain works well, then yes, absolutely, it can reinforce learned pain. It can reinforce that spot is pushing on that spot is dangerous to the brain. What's really interesting is once people understand how pain works, you can actually use touch and you can use pressure to actually start to give the brain a new input that is actually more safety oriented. So we don't like to minimize the benefits of manual therapies and other types of body work, just like we don't want to tell people that they have to, always give up all their medications. We don't want to tell people that movement isn't helpful, because movement is helpful. It's another way to hopefully reinforce safety to the brain if it's done with the right intention. And it's actually a really important part of getting back moving again. So these bottom-up strategies, as I call them, where we're giving new input to the body, to the tissues, that then goes up to the brain as new information. These can be either really helpful in unlearning pain, or they can actually be reinforcing danger depending on the context. I guess that's how I answer that question.
Yeah, absolutely. Hey, there's another question I'd love to address here. Does this work for IBS, irritable bowel syndrome?
Absolutely. Absolutely. What's so interesting about this work, about primary symptoms, we'll call them, is that the brain can choose any symptom it wants to try to get our attention. And it's usually really sneaky and pick something that really will get our attention more than other body parts. So as a runner, my brain might choose heel pain, right? Plantar fasciitis or something like that to get my attention. Someone else who maybe has a family history of IBS, or let's say they have a parent who passed away from some type of cancer, they already have sort of preloaded this fear that the digestive system might be vulnerable. And so the brain might choose IBS or those symptoms, we won't even label it IBS, to try to get that person's attention that something's not okay. And I actually have a client I'm working with right now who's right at the verge of retiring. And he has some other fears that play into this as well. But for him, retirement is really, I'll say, exciting in one way, but also really stressful, and really is part of, his work is part of his identity in another way. And it's really important to recognize that and to normalize and honor that. And as he starts to make connections between what he's working on in a given day or what's coming up for him as he makes this transition to retirement, he can start to see that the symptoms are behaving in a way that tracks really closely with his stress and with his thoughts and with his feelings and even meetings he's having, right? And this is one of the ways we make this diagnosis, positive diagnosis, is to really look at symptom behavior. We sort of build a case. We're like detectives, because when all these other things aren't working and we've ruled all of that out, then the work that we do at Lynn is to help to rule in the brain and nervous system by building a case.
Charlie, let's do something real quick. Let's do a quick back and forth and just list our favorite pain-related symptoms, presentations. So IBS would be one. Let's see if we can, I know the list is long. Tinnitus is one that always was interesting to me. Definitely falls in this category. A lot of pelvic pain, vulvodynia.
Yeah, there's a comment in the chat about vertigo, and dizziness is a really common symptom that shows up at times of stress for people. It's disorienting, and it's sort of a metaphor for how people feel oftentimes in their lives. And objectively, the symptoms aren't particularly helpful, right? Because you're already dealing with something stressful. So why would the brain choose vertigo and dizziness, like, to make it even worse? But
it definitely does sometimes.
It does, and it's very common. So vertigo is another one. My headaches are a really big one. And we've seen all kinds of symptoms, skin rashes. The list is really long, but all the pain patterns we know so well, knee pain, shoulder pain, neck and back pain, things that we used to call tendinitis.
Carpal tunnel, repetitive motion, a lot of that is the same kind of thing where it's actually, I have one client, I'm picking up my keyboard here because we joke a ton that her keyboard is actually not a lion, it doesn't bite. It's actually perfectly safe. But she's definitely, learned associations, some having also in her case to do with some things that were happening at work to the keyboard that present as tingling in her fingers, because she's always been worried about, I might get carpal tunnel because that sounds so scary.
And you and I, Abigail, are sort of immersed in this world, right? Like we're so comfortable talking about this, and we need to be a little bit careful not to minimize the fact that these symptoms are very real, right? So we can talk about the diagnoses of the moment right now, which are things like POTS and mast cell disorder. And, for a while it was fibromyalgia, and there's chronic fatigue, right? These symptoms are really real, and they have massive impact on people's lives. So it's not to minimize and say that these things aren't accurate, but what we've done is we've started to label symptoms, right? We started to put a label on the symptoms, which can cause a lot of fear. And what we're saying with Lynn is, we don't need to label these symptoms. We can acknowledge and recognize that they're real, but there's actually a different mechanism that's driving, people losing consciousness or getting dizzy when they stand up.
And that's really back to this primary pain diagnosis, which is best diagnosis in the world to receive, because it is really reversible, treatable, and means that your body is in great shape, which is an amazing, amazing thing to learn, especially when one has been really worried about what's happening. Hey, there's another question I think really kind of the nice follow on from this is, how does Lynn fit in with other treatments like pain creams or patches? Also, do we support people getting off their medication? Do we encourage that they need to do that? How do we work with their prescribing physicians?
That's a great question. I think it's important to say that it all belongs, right, to a point. I have a very simple flow chart when I'm talking to people about this, and it really has to do directly with fear. So should I be using a patch? I ask, is it reducing fear for you, or is it increasing fear for you? Is it becoming a dependency? Is it becoming something you can't do without? If you don't have it, does it make your symptoms worse because you're scared you don't have it? And if that's the case, we need to work with that. But if it's something that really makes you feel safe and hopeful that it's going to help, then sometimes it can work really well in combination with what we're talking about, even if it doesn't necessarily address the core issue, right? Even if it doesn't address the cause directly, anything that is going to reinforce the tendency of the brain to be stuck in danger alarm is potentially going to turn the pain down, at least temporarily. So I think there's room for all of it.
Absolutely. And what just in terms of the Lynn, I don't want to call it the party line, but the Lynn approach is whatever you're doing with your prescribing physicians, great. That's really not our job is to suggest any changes there. Although we love working with your physicians, we really pride ourselves in our ability to work with teams in the community and are delighted to do that on behalf of our members. What we want to do is give you some new tools and watch how far we can, together work with those new tools. I'll give one great example. We have one member who came to us right before she was having her 4th back surgery. She'd had 3 failed surgeries, was literally 2 weeks after joining Lynn, going in for another back surgery. And we supported her through that. That was a medical decision she had made. But what we wanted to do is make sure that she came out of this next back surgery with the fear way down and with everything we could do to help her stay out of that fear pain cycle around the surgery. And the good news is this last one was incredibly, incredibly effective, and she's back up and walking and getting her life back. So we really see that as our role, is to do everything we can to work on this brain-driven component in conjunction with whatever else feels like your medical team is recommending or you feel like is helpful for you, especially helpful for reducing that fear. So we probably have time for 1 or 2 more questions here. Can you talk about old injuries that come back and start hurting again years or decades later?
Despite having, let's say, positive findings on an MRI scan in the neck and back, disc bulges, disc herniations, arthritic change, these are things that we know are just normal in people that have no pain. So a lot of the time, these findings we see on scan are not correlating well with pain. So a lot of people have these findings on scan, but the pain goes away, and then it comes back, and then it goes away, and then it comes back. And it's really interesting to start to map out sometimes what was going on for that person in their life every time the pain showed up again. Is there a pattern? Is there something significant going on? For some people, they can make that connection really easily. For some people, it just seems kind of random. But in the absence of a physical injury, which is in my practice, the most common way pain starts, is people are like, I don't know, I wasn't doing anything. There wasn't a car accident, there wasn't an injury. This is like 8 out of 10 of my clients have no reason that their pain started. Then we start looking for these other factors, these other psychological and social factors.
So we're going to start wrapping up here. I'm really appreciative to everybody who's been sending in these great questions and taking time out of your day to listen. I hope you've heard some things that are new, interesting, thought-provoking, and hope this is the beginning of a discussion, between you and yourself, or you and people that you care about, but also between you and our team. And just want to make sure everybody on here knows that our team is here. You can call us whenever you want. The number's on our website. You can click in and send us a message. But our team is really here to talk with you about, hey, in my case, could this be what's happening? We love those conversations. So do feel free to reach out, more than free to reach out. Please reach out. And just a little bit of on the incentivizing that reach out to. We do want to make sure everybody knows that anybody who's been on this webinar, we're delighted to get a little bit of poll answers on kind of your readiness and what you're thinking about, but also to offer a 15% discount off your first month at Lynn. So the code for that discount is WEB15, WEB, and then the number 15. We're thrilled to offer that if it can help you kind of see it as a little bit of a motivation to get yourself to take a look at a really different way of moving forward to the other side of pain, but in a way that's really, really supported and not have to journey along on your own.
There are all these amazing questions in the chat, and I feel a little guilty as a clinician because I just want to help everybody. I feel a little guilty not being able to answer all those questions directly. And I just want to tell you that as I notice that feeling of guilt, what I feel is a little bit of tension in my head, right? This is playing out in my body. Every emotion has a physical sensation, and every physical sensation has an emotion. And so I just want to use that to bridge to, I want to be able to answer all of your questions, and I hope we can do that if you join us in Lynn and you choose to come in and try us out. We want to be able to address all of these things.
Absolutely. So thank you again so much for spending time with us. Our team is here if we weren't able to get to your questions. Please do reach out. We really look forward to hearing from you. And again, that code is Web15 for anybody that wants just a little motivational push to help you motivate yourself to come check out Lynn and this approach to moving through to a really different place in terms of pain. Have a great day today, and we look forward to hearing from you. Bye-bye.
Thank you, everyone.
Thank you, Charlie.
Thank you, Abigail.